Slides.
Don't see your slides yet.
All right, let's see if I can get it to share.
Oh, you know what? That might be my fault. Okay, go ahead now. That's my fault.
All right.
There we go.
Now I just got to see it as a slide. How's that? Do you see it right? All
Yeah, that
right.
looks
So
great.
here's where we are in 2024 in medicine. Let's just remind ourselves what I'm going to really be talking about is buprenorphine for pain, and moreover how we can get there. I'm going to go through a little bit of what we talked about last week or 2 weeks ago, where this is the why. Remember, if you remember, what we're sitting in this world is the CDC says there are safer ways to prescribe and less safe ways to prescribe. And we have lots of patients on medications that may or may not be helping the way we want, but the risk is sometimes higher than we wish. And we're not getting anywhere with our prescribing, or we inherit a patient and we think that we can do a better job, or they develop comorbidities that mean that we should go in a different direction, yet we're trying to make their symptoms better. How can we do that in a way that's patient-centered, thoughtful, and appropriate, keeping in mind that the CDC and the DEA, as well as all other kind of regulatory agencies, want us to keep the patients comfortable. They don't want us to force taper patients. They don't want us to kind of impose something on a patient. And one of the things I think it's really critical for us to emphasize over and over again, that we're working with a patient and maybe they're developing problematic use patterns with medications that we've been prescribing, we don't fire them for that, right? This is not the kind of thing where we want to throw out the patient-physician relationship because things aren't going well or patients developed a problem with use pattern. We want to leverage our relationship with the patient and move them in a more positive direction. And so the goal here today is to give us the skills to do that. Fortunately, when it comes to opioids, prescription opioids, using these medications for pain, we've learned in prior studies that they're not particularly effective, although it's something that we've been doing for at least 25 years pretty intensively. And so we come across the concept that these high dose opioids aren't working for patients' chronic pain, but if we take them away, patients invariably say, well, I hurt more. So why are you doing that, doc? You're trying to treat my pain. And what we can have learned is that the use of buprenorphine is uniquely effective and more effective than opioids in the majority of legacy opioids in the majority of cases. It's just a matter of how do we translate from something that's not working into one that is. How do we translate from something that may be not safe into one that's less unsafe and more safe? And so that's what we're going to be talking about. So let me just go through, remind ourselves some of the studies, even high dose opioid management. So MME dosing of 200 to 1300, mean dosing of 500. If we switch patients over to buprenorphine, they have a reduction, not an increase in pain, right? A very meaningful reduction. 50% reduction in VAS is not something we can accomplish with legacy opioids. Quality of life improvement is noted as well. A little counterintuitive until we start thinking about the receptors and the molecules and the physiology, which is beyond us. Another study I talked about is even with high dose opioids, patients on low dose legacy opioids to high dose legacy opioids. Remember this study, if you were here a couple weeks ago, 90% of patients were successfully converted, and that is irrespective of where they were. What people got was a reduction in MME, even if they were on greater than 200 to start with, and they had a pain relief that across um, all dosing ranges was meaningful, with improvement in pain relief with reduction in MME. Successfully converted, greatest pain reduction was actually in patients who had been on the highest dosing. So the worrisome patients, the one we're most concerned about, will do better on buprenorphine if we can switch them over. With respect to chronic pain, And I remind you, all of those studies that we talked about last week were completely independent of people with opioid use disorder. We're not talking about people who had been misdiagnosed and had opioid use disorder. I'm going to go past this. I put that in the wrong spot there. Sorry, guys. So why this is remember, buprenorphine was originally a pain medicine. It wasn't until data waiver came out, that's now gone away, that we started thinking of it as Suboxone rather than buprenorphine, and we started using it strictly for office-based opioid therapy. Buprenorphine is uniquely effective because of how it affects the receptor and how it works with second messengers in a more beneficial way. It's not partially effective, it's a partial agonist, but it's very sticky. It stays, it's very, it has a lot of affinity for the opioid receptor, and therefore it's more effective, greater analgesic efficacy than morphine, fentanyl, oxycodone, methadone, and hydromorphone. But then there's also this therapeutic index that we can talk about. Therapeutic index, as we know, it's the dosing range between toxicity and efficacy. And since there's that ceiling effect on respiratory suppression with buprenorphine, that means that the upper end of the therapeutic index is elevated, right? So what we have is a much greater therapeutic window if we know how to use that therapeutic window to reduce pain for our patients. Also, it's got really easy to follow interactions with other substances, so we don't worry about that. All of these are things we've talked about. So therefore, we can use it in high BMI individuals. We can use it with people with obstructive sleep apnea or problems with COPD, what have you, and we're generally feeling it safer. This is something we will be using, talking about it today. Remind when we're using opioids, legacy opioids, or when we're using buprenorphine, if individuals are being prescribed medications, only a subset of their receptors are filled at any one time, and we use that to our advantage. So what we need to remember about this is that even at low doses of buprenorphine, 60% of mu opioid receptors are available. When you see this 2 milligrams of buprenorphine, when we're typically working in the pain space, we're not talking about opioid use disorder, so we're prescribing buprenorphine for pain. We're very commonly at 2 milligrams, not very frequently are we above 4 milligrams. That's different than the dosing for opioid use disorder. Those of us who are familiar with the brand names like Butrans and Belbuca, remind yourself that those are always in the microdosing ranges, right? They're micrograms, not milligrams. And for the purposes of just the translation, we can fully give somebody good, meaningful pain relief, perhaps at 2 milligrams of buprenorphine once, maybe even twice a day. We're still getting half of their receptors are available. And so that means that what that means is that we have an option to translate them directly from their legacy opioids into buprenorphine. The consternation that we have, the idea that we have is that you can't do that because we've been talking about buprenorphine as Suboxone in the 8 milligram or 16 or 24 milligram daily dosing for people with use disorders, and we don't really know what they're coming in on. So in that case, we were always very careful to induce withdrawal and measure the Cow scale and make sure that they were in moderate level of withdrawal before we start opioids or before we start buprenorphine. But we have kind of mastered the idea that we don't need to do it that way. We can directly translate people if we're talking about moving from legacy opioids for pain relief into buprenorphine. And so that gives us a lot more leeway and management options, and that's what we're going to talk about. When do we want to consider that? When do we want to consider that? We talked about all the effects. So the concept, what we're talking about today is buprenorphine microdose initiation or the Bernese method is one way we talk about it. We can use this for people with opioid use disorder, and we have, but our data shows us that if we're just switching people from legacy opioids for chronic pain into buprenorphine to improve pain relief, efficacy, safety as well, we can translate directly over without forcing them into withdrawal. And that brings us into this point about stigma, right? Stigma is really an important concept not to overlook. It's very detrimental to the whole process to move patients over is to say, we're going to do this because the CDC wants me to, or I'm not allowed to prescribe opioids for you, or I think maybe, you're developing a problem, or maybe we really need to couch this in terms of, because I want your pain relief to be more substantial, because I want it to be more sustainable, I'm going to switch you into a more effective medication. You're going to find that we have to work through the process of switching over, but what we get on the end is a reduction in pain relief, an improvement in sustainability in a long-term management fashion, and 3, I'm going to liberate you from having to wonder when your next dose is due, if it's in 4 hours or 5 hours, or did I remember to take enough Percocet for my weekend away, or what have you, because we can really leverage the pharmacokinetics of buprenorphine with its 35-hour half-life into a patient who doesn't have to think about their medicine all the time. Most of our patients on chronic pain management with buprenorphine are managed either once or twice daily. We can prescribe them a full month with 2 refills safely, and then we are working around other issues. We're not just always counting how many pills they have and whether they used more than we wanted or whether they've lost effectiveness and what have you. So to do this, we want to really also, this is where some of our language that we need to remember from our previous use of buprenorphine with respect to opioid use disorder is very important. It's really, really critical to communicate with your patient that this is something you're doing for improvement in pain. Use your motivational interviewing skills to say, I've got a better idea. It has a lot of data. If you can hang with me, I can show you something better. And another thought about this that I think is probably critical is you want to be strategic about your timing of this. It's important not to force somebody into tapering. It's important for them to have a chance to adjust to this. It's very normal for patients to be anxious when we're doing this, and anything you can do to reduce that anxiety is going to improve your likelihood of success, because there are bumps in these individuals as we switch over in the first 3 to 4 days. And if you can kind of predict those bumps for them and make sure that they know that we're in it together, you can get through those very successfully and do it. So really be thoughtful about this. And even we will, those of us who know our practice, we will even, it's very common for somebody to get, just enough Dilaudid or Percocet or fentanyl or what have you to get to my office on a first visit. And it's clear to everyone that the idea is to wean away from the medication. I think it's very important from our standpoint to initially prescribe those medications with the patient until they get to know us. We'll tell them, hey, we're going to probably go in a different way in the future, but for now, let's keep you going on these legacy medications. Let's follow what's going on. Let me give you a chance to adjust to this idea. And then once they trust us, we move forward. So be thoughtful about that. So all of these ideas are when it's a good idea to move a patient over with the Bernese induction. In the pain space, I think it's just perfectly the way to go every time. But you can also use microdose induction of buprenorphine to fully treat opioid use disorder. So you don't have to force an individual that may be misusing fentanyl. You don't have to force them into a period of withdrawal and hope that they stay with you and come back. But certainly in the pain space, it's a very good way to do this. And here's what you remember. What we really want to understand about buprenorphine is that the doses are logarithmic in this chart, but the opioid effect as a partial agonist means that as you get the receptors fully filled up with or as much so as you will, that's about 80%, you're not going to get full-on respiratory suppression. Once you get to the very, very high doses, that curve bends down to zero, and so higher doses are not going to give you respiratory suppression or the other adverse effects. That's different than methadone, and of course, it's different than any of the other opioids. So theoretically, what we're doing with the microdose induction with buprenorphine is we are using very small doses of buprenorphine co-administered with their legacy opioids. So you give them intervals of low doses of buprenorphine, and at any given dose of any opioid, a subset of the receptors are not filled, right? You saw maybe somebody who's taking high doses of fentanyl and oxycodone, they still have perhaps 40%, 30%, up to 60% of their receptors are empty. So when you use low dose buprenorphine, what you're doing is you're just allowing that buprenorphine to fill in to the receptors that are unoccupied. And so as it fills in, it comes in slowly, but it connects more robustly. So it will outcompete the other opioids at the receptor in a fashion that's very gradual. So when you use low doses of buprenorphine and start it up, and you're giving the legacy opioids, if a receptor is filled up with fentanyl or filled up with oxycodone, it's not available to the buprenorphine, but the buprenorphine will go to an unfilled receptor. And then as the relatively shorter acting other opioids are released from the receptor, then the remaining buprenorphine is going to sneak in. So the concept is going slow, going very gradually, and moving the patient up. And then once the buprenorphine has replaced enough of the other legacy opioids with the receptor, then an individual can just stop their legacy opioids and they never go through with the withdrawal. And the nice part about that is, at least I would recommend, and I think most others in this who use this would do so as well, allow the patient to pick the pace of that. Allow the patient, you're not going to force a patient to stop their medication. You're going to add buprenorphine and say, come off of your other medications as you can. And the key part of this is to remember that as we have learned with some of the other lectures in this series, the reason that opioids aren't effective for chronic pain is that they don't work in this nervous system change that occurs with chronic pain physiology. But what patients perceive as effectiveness is that opioid abstinence effect, right? How many times do you have a patient say, I don't know if the hydrocodone's working for me anymore, but I know I feel terrible when I don't get it, right? What they're telling you right there is they're feeling the abstinent effect of the lack of opioids, and they misperceive that as efficacy. So it allows us to not have to have that period of time. So patients look up and they say, you switched me over to buprenorphine and I just feel better. I have less pain. I feel more like myself. I'm less cloudy. I don't feel up and down all day long. I just feel better. And despite some counterintuitive nature to that, that's just what happens in these individuals. So here's the protocol I like to use, and I'm going to show you several other protocols, and it isn't important which one you use. It's just kind of helpful to think of it and what works. I like this protocol because for our clinic, it works with a wide variety of individuals. I will switch somebody over who's on maybe 60 MMA a day of morphine if I don't think it's effective, or if they're frustrated by it, or if they're starting to go up on the dose with lack of improvement, or maybe they've just got comorbidities that make us worry about it. A little old lady with, OSA or COPD who lives at home, what have you. So what we'll do is and the other advantage of this one is that it doesn't use any of the expensive branded agents. It's very easy to do this with, for example, Belbuca, which comes from 75 micrograms up to 900 micrograms, but that's very expensive, right? And a minority of patients have access to this. So what I like to use is the generic buprenorphine, which comes as a 2 milligram film or a 2 milligram tablet. Remember, it's completely irrelevant whether there's naloxone in it or not. The only reason I worry about naloxone in this patient population is whether they have access to it on their insurance plan, because insurance companies in their never-ending, you know, kind of hesitatingly following the rules, they will allow for Suboxone to be on their formulary, and maybe buprenorphine without naloxone isn't. It's meaningless, and it gives people a misperception of it. But I'll oftentimes use buprenorphine, and I like to use the 2 milligram film a little bit better than the tablet, because you can cut that into quarters. When you're cutting a 2 milligram buprenorphine film into quarters, now you've got 500 microgram quarters, and a patient can use 1/4 of a film once or twice a day, and that's very cost effective through the month. And it also is a good dose to translate. And so what I'll do is I'll just say on the first day, use 500 micrograms once or maybe twice a day. Do it for a day or two. It gives them a chance to sort of get it on board. They're not going to be at a steady state for, 150 hours, because it's 5 half-lives of 35 hours. So we're just gradually building it up. Day 3 and 4, maybe we'll go to 500 micrograms 1 to 3 times daily. So you get them up to 1.5 milligrams of buprenorphine. And then that's the period of time where most patients, if they're just being managed for opioids for chronic pain, now you can say to them, just think about whether or not you need that Vicodin or that oxycodone or what have you. And just allow them. A lot of times I'll just guess where I think they'll be best at removing the medication that they're on, and they won't need it. I usually wait 3 or 4 days, because you need that period of time for the half-life of that medicine to build up, for the buprenorphine to build up. But then once you get to 3 or 4 days down the road of 1.5 milligrams or maybe 2 milligrams, most of the patients by that point will be getting more opioid than they're used to getting in their legacy opioids. So it's a good time to say, maybe back away, because if you don't, you'll overshoot over the next few days, and that can be one of the challenges here. If you get a patient to day 9 or 10, so let's imagine I would do this on an individual who is, maybe they've been prescribed in a way, they're on 100 mics of fentanyl, and they're taking 6 oxycodone a day. They're at a pretty high MME. I will sometimes wait till they get up to 4 milligrams daily on their buprenorphine before we suggest weaning away. And even then, sometimes after 7 or 10 days, an individual will want to take a little bit of their hydrocodone or their oxycodone and what have you. And at this point, it's almost they're doing it probably out of anxiety and or stress, because you're really covering the receptors effectively at 4 milligrams, even better than what you were doing, unless they had a use disorder. So very often, once, we have to tell patients, once you get to 4 milligrams daily, at that point, we're going to have to make a decision to get off of our legacy opioids and go forward, or we're going to have to kind of reassess and see how things are going. And I think most anyone's experience, if somebody gets to 4 milligrams daily and they say, I still don't feel well, I feel like I need more help, I'm not feeling more comfortable, at that point, what you're probably really working on is a patient with a little bit of an indolent coexisting opioid use disorder. Very common, not anything dramatic, but that individual may well go on to 4 milligrams, 8 milligrams, 12 milligrams. That's okay. We just do that. We fill their receptors up until they tell us, I feel better. And the interesting part about that, I should say, is that sometimes this is a way for us to get an idea as to how much of the benefit they were getting from their prescribed opioids was really kind of treating unrecognized use disorder, right? If an individual is going into those higher dosing, then probably what they were responding to with their legacy opioids was the dopaminergic effect as a second messenger with the opioids. So they're really telling us I had a bit of a more of a problem than we knew. So it means that it's a little bit more important than we switch over. So the next part I want to talk about that is everyone says, okay, well, those are the numbers. There's some other ways I can show you some. Actually, I will show you a few other microdosing process. Here's somebody very similar, but these are individuals on this one you're going all the way up to 8, 12 milligrams. Those are individuals we're treating for use disorder, right? So this is another one, and this will be included in the slide. Another sample this is pretty similar to what we use. You don't want to talk about the relative affinity for the receptors. That's too much for today. You can use agents. You can use the Belbuca, the branded versions. You can use transdermal, the Butrans patch. Remind yourself that when you get to 20 micrograms, the highest dose of Butrans patch, you're still just at about 0.5 milligrams daily in dose. So the full-on Butrans patch is the same as the 0.5 milligram buprenorphine that I'm talking about creating by dividing that generic one in half or in quarters. So what are the problems with this, and what are the issues that will develop with this? The issues that the patient will have will always be in the first 3 or 4 days, maybe 5 days of that, and it's related to the rate at which the buprenorphine is coming on board versus the rate at which the old legacy opioids are dropping down. And so a patient will very often call. By very often, I would say 20% of our patients call back and say, all right, I'm having some side effects. I don't like this medicine. It's not working. This is where we want to be confident as clinicians. We want to lean in on the idea that we've worked with our patient. They understand that we're making their pain better, and we want to problem solve with them and not just jump back to their legacy opioids. We get that a lot. Patient calls and says, I'm allergic to it, or it doesn't work, or it's causing this. And if you listen, and we coach our staff who's answering the phone, listen very carefully, hear what they're describing, because invariably what they'll be describing is either evidence of over medication or under medication. They will say to us, I'm sleepy and I'm nauseated. Okay, I went too fast. So you need to back down to 0.5 milligrams, maybe daily, or 0.5 milligrams every other day is an effective dose for some people. It's a little bit like taking 250, 150 of Belbuca BID, but back them down until they say, all right, I'm not having drowsiness or nausea. A lot of times we just coach them that say, yep, all opioids give us some nausea at first. We're going to give you Zofran for a few days, and almost invariably that nausea goes away after they get acclimated to the dose of the buprenorphine that's appropriate. But the other thing that I think that happens very commonly is the reason they call back and say they feel terrible. They'll say, I just feel terrible on it. I can't tell you. Everything's bad. Nothing's working right. I hate this medicine. I want to switch. What we've done is we've underdosed the rate at which we increase it. So we're leaving too many receptors unfilled. So it's simple. Let's try another 0.5 milligrams. Take another quarter tab now, and let's talk in 4 hours and see if you're better. And most of the time they say, yeah, I'm better. And I've had it in a few cases with very high dosing prescribing and what have you. I've had a few people come back at a week, even 10 days, and they're still unsure whether they like it. But I can't stress enough how many times at 2 weeks or 3 weeks those patients come back and they say, oh my gosh, I love it. I feel so much better. My pain is better. I feel like myself. They come in, their family members are like, I don't know how you did it, but it looks better. I like it. It's better. And the neat part about that is then 3, 6, 9, 12, 48 months later, they're going to stay better. And they're not going to call up and say, well, 7.5 is not working. Can I have 10? TID doesn't work. Can I have QID? They'll get to that dose and they'll stay there because the medication's going to maintain its efficacy over time. All right, so I talked about a lot, and the buprenorphine, most of that is in there, but I kind of wanted to really make this a little bit more like we often do with echoes and go over a couple of cases. And if I can find where I laid out that slide, we had somebody, I have a couple of cases that I can go over. I'll go over one, and if we have time, another one, and we'll sort of emphasize the principles. So this is a great time if somebody has questions, or I can get into a case and we can kind of talk about how we do this. Anyone, should we just move into the case study?
Yeah, I'm not seeing any questions in the chat, so yeah,
All right.
that sounds good.
All right, let's talk about this. So this is one that was sent in to us, and thank you very much for that. This is a 42-year-old gentleman with a mitochondrial disorder and chronic right upper quadrant pain. A lot of medical comorbidities that make management difficult. One of those being pseudotumor cerebri, hydrocephalus, cluster headaches, associated depression. So you can see right here that this would be an individual that is likely to have a difficult time being managed effectively with opioids of any type, but we always try that, right? Right upper quadrant pain, don't know what it is. Let's see what this does. It works for a little while, and now it's not. Let's use a little bit more. Now it's not. Somebody has gotten into that trap. Maybe we've inherited this patient. Maybe we've just been managing the other issues and just kind of inexorably increasing over time. But now we're sort of realizing it's not working. How do I switch over? Yet, this is the kind of patient who would not do very well if we said, I want you to get a COWS scale of 12 or 15 before we move forward, and we're gonna go through 48 hours of withdrawal, and good luck with that. Come back in, I'll start you on this new medicine. Don't want to do that. There's no reason to do this. This is not an individual who's misusing medicine in any way. It's just not effective. So how do we translate fentanyl plus 40 milligrams a day of oxycodone into buprenorphine therapy? I didn't do the MME conversion before I got on with this today, so I'm sort of at a loss. But if I was looking at this, I'd be thinking we're somewhere above 100, maybe in 100 maybe to 150 MME range as a good guess. So we can directly transfer this patient without any difficulty. We just need to think of the strategies involved. And to get kind of quickly to the answer here, the first thing we want to think about is the fentanyl. The fentanyl is the first one that we want to kind of help ourselves out with. So fentanyl is a short-acting opioid, but since it's being delivered transdermally, you're getting 50 micrograms every hour, right? So it's ongoing introduction into the opioid receptors. The oxycodone, 10 milligrams QID, is coming in, leaving, coming in, leaving. So there's lots of opportunities to switch out. So my approach, my suggestion on this as a way to manage this is to initially tell the patient, what I'd like to do is get rid of the transdermal fentanyl. Let's take the fentanyl off, even if what we have to do is cover that missing receptor of fentanyl with oxycodone. So we're not going to taper somebody. We're just going to translate from a long-acting opioid delivery system into the short-acting system. So let's say that what we're going to do is we're going to take that transdermal fentanyl off, and we're going to go to perhaps oxycodone 10 milligrams, an additional 20 milligrams of that a day. So we're going to go to 6 times a day with that oxycodone. All right. And you're going to do that for a day or two to allow that fentanyl, that long-acting delivery, to go away. The fentanyl gets away, and they're on oxycodone. It doesn't matter exactly to you how much oxycodone they use. I just want the individual to feel approximately the same on the oxycodone as they had felt on the fentanyl and the oxycodone. And then about a day or so after, let's say maybe we take the fentanyl off this time in the morning, and then we give them a little extra oxycodone for that day, so they don't go into any withdrawal. They don't feel like they've had any lessening in their medicine, but we switched into a short-acting agent. And now what I'm going to have them do is start that 0.5 milligrams sublingual of the buprenorphine once or twice a day. Okay. And we're going to just do that twice a day for maybe 3 days. This individual who's on maybe 150 MME, maybe a little more, I should do my math, is going to be relatively better with pain relief somewhere most likely between 1 milligram of buprenorphine and 2.5 milligrams of buprenorphine, depending on a lot of other factors. But that's not going to really show itself up until after about 4, 5, 6 days, right? We need 5 half-lives to reach steady state. Steady state is 35 hours times 5. That's almost a week. So you start this patient on the 0.5 milligrams of the buprenorphine twice a day, sublingual, and you just say, the first day when you take the fentanyl off, go up on your oxycodone a little bit. And then after that, once that's on board after a day or two, just go back down on oxycodone as you see fit. Help somebody do that. They can come down. They can stay on 4 of those a day for a few days if they want. They can go to 3. Encourage them that as this more potent medicine comes on board, just remove that at the rate that you think that you can. And it's really that easy because they don't feel in that fashion that you're taking medication away from them. You really want to emphasize we're giving you a more effective medicine. It's more potent, it's safer, but it's going to also make you feel better. And so they kind of remove that anxiety, if you will, of you're taking my medicine away. Let them pick their path. One obstacle to this, and one thing you have to negotiate, working a lot with pharmacists around, is you'll oftentimes be sending in a prescription that says, in this case, I might send a prescription to the pharmacist that says oxycodone 10 milligrams up to 6 times a day for 10 days. So I'm giving them 60 while I'm giving them a prescription that says buprenorphine film 2 milligrams, 1/4 film, titrate to effect, begin BID. That's going to send a lot of pharmacists kind of like, what? Because they're not sure what you're doing. So you want to kind of communicate with your pharmacist. But once they understand what we're doing, then they can make sense of this. And it usually will take about a week up to 10 days before you get all fully translated. But once you do, this individual is going to do very well. They will never have to go through withdrawal. What they'll notice is at first the medicine is equivalent to what they're on. And then after 2 weeks, 4 weeks, 6 weeks, 8 weeks, it's superior. And that's because it's kind of resetting their receptors. Things are getting back to normal, and they're not getting the negative effects that those opioids were giving them, despite the fact that they thought they were beneficial. Does that process make sense? All right. I can go into another case, but I'd love it if somebody would ask me questions or challenge me or ask for
John, there's a question in the chat. Are there any studies or recommendations for use of buprenorphine for chronic pain secondary to fibromyalgia? And I'm going to go ahead, and I'm not answering that, but the next question is, do most pharmacies have the film? And yes, it's true, most do, but they'll get it right away if you're going to start using it. Okay.
Good answer. So there are not specific studies for buprenorphine for fibromyalgia, but for a number of years in the US particularly and uniquely, the #1 prescribed medication for fibromyalgia has been hydrocodone. And we know that hydrocodone, when you measure fibromyalgia patients with hydrocodone versus those without, there's consistently at least 30, if not 40% more pain in individuals with fibromyalgia managed with any opioid. So the efficacy of buprenorphine for fibromyalgia would merely be, in my mind, there's not data on this, would be in removing the harm, the negative effect that the opioids give for that. So we will very often use buprenorphine to get people away from something that isn't working. We're not feeling like we're making a benefit with it. We're just taking away a negative effect. Good question. That's comes up a lot. And I think it really, if, you know, it's pretty scary to look at the lack of efficacy of opioids for chronic pain. They just don't work. But once people get to them, they feel worse off of when they come off of them. So it looks like they work. So this is a way to make that difference. Great question. Thank you.
We've got another one in the chat asking, when you get a patient started on buprenorphine, how often are you seeing them in the office, or are you doing multiple telehealth visits, or just giving them a written schedule of induction and having them call your office?
Great, very good question. So when we do this, what we prefer to do is we really strategically pick when we start it up. We do, I mean, we'll carry somebody on medicine we don't like for a month or sometimes a couple months, allow them a chance to get questions answered, bring in family, kind of challenge us, what have you. But then once we start it, I think it's really beneficial to visit with a patient at a week if you can. If not, you can avoid it a lot. But at that 5 to 10 days, that's when they're going to come in and they're going to say, well, it's kind of working, but something's not quite right. And you really want to listen to what they're saying. Are they being overdosed a little bit? Are they getting a little withdrawal? So they're being underdosed? Are they edgy? Does everything bother them? Are they anxious? Or are they having side effects? Am I drowsy? Am I nauseated? Which are the main ones? Then you're going too fast, and you reassure them. And then that's your chance to write for something like clonidine or clonazepam, or just to change the titration size. So I like to see them at a week or at 2 weeks after initiation for sure. And then I like to see them at a month. And the first few times I'll see them like we have monthly or something like that. And then you can prescribe this as a C3. You can prescribe this at every 3-month intervals. You can give this medication. So if I have a stable patient and let's say they've been on 2 milligrams sublingual once or twice a day, and they're stable and they're functionally doing well and on their medication, it's acceptable to see them every 90 days and write, 60 films with 2 refills. DEA does not let us go beyond 90 days for any scheduled drug. Remember, that came out very clearly last year in their guidelines, whether it's tramadol or buprenorphine or even Lyrica. These people are that stable. They'll stay on their dose. They don't take more than they're supposed to. And really, if they did, that just probably tells you you're not giving them enough anyway, right? So have that conversation. Good question.
Not seeing anything else in the chat right now, so we
Okay.
can go to that other case if you want.
All right. I don't have a okay. I don't have a slide for this other case, but this other case is one that came into our clinic, and this is an individual who has a history of significant scoliotic deformity, had multiple surgical interventions over the course of years, has fusion from T10 to the sacrum, and then for some reason from T4 up to the upper cervical with a gap in between, and persistent pain and pain in multiple areas. They've been talking about whether or not to do surgery. That they're not going to. The bone density is not good. The individual has a history of COPD at this point. Obviously, the spinal deformity plays a role in that. A lot of anxiety, a lot of deactivation, persons on disability, and they come into us and their current regimen is morphine, ER, 60 milligrams, BID, hydromorphone, 4 milligrams up to QID, along with Xanax and Lunesta at night for sleep, and pregabalin and duloxetine. So this person's describing pain, 7 or 8 out of 10, not doing well, came actually came from out of state to our clinic, and what they wanted to know was whether I would consider them for a morphine pump, intrathecal drug administration system pump. They were told by their new primary care physician that they don't manage opioids and they needed to find a provider, and their local provider wasn't going to take this on, and so they came to us with a referral for a morphine pump. How do you address that? So let's use the echo format and see if people want to ask me questions about that and kind of come up with strategies. We've got about 10 minutes here, so I'm really willing to answer any questions or just proceed however you want.
Got a comment in the chat, orthopedic medicosis.
I am not commenting on that, but I understand. Yeah.
You know, I think that person with those multiple medications, you know, what that means is that really that has been a struggle for years. A lot of different medications have been added, none taken away, which we're all guilty of. I think, I don't know about that person for sure in the history, but I'll bet there have probably been multiple providers. And so I think it's really important to take time to really establish that relationship and trust. And, you know, because things have not worked clearly. And I think you're right, John. I would probably, you know, leave them on what they're on pretty much as you get to know each other. And I think a message is, you know, I'm committed to helping you work this out, and I'll stick with you, you know, and if you'll stick with me, we'll work through this together. But I think, you know, in that situation, you've got to establish a relationship first, because there's been a lot of stuff going on.
Those are just really excellent points, Janet. That's exactly it. I'll throw this kicker in, is that you know, the reason the original prescriber wasn't prescribing anymore was that that individual was in trouble in another state and could no longer prescribe, right? So this was really a medical orphan at this point, and desperate, through no fault of his own, we must add. And this is a time to say that the CDC wants us to keep prescribing that. They do not want that individual to have somebody say, no, you know, get out of my clinic. They want us to continue to prescribe that patient as we come up with a better plan. So excellent points, Janet. Yeah. Anybody else want to suggest a strategy or ask a question? So in this individual, what I can tell you from a pain provider standpoint is this is in 2010 or 25, maybe 2005, there are a lot of providers who would say, yeah, let's give this person an intrathecal morphine pump. And we learned through a lot of pain that won't work. If you've already wrecked the mu receptors by what you're doing, switching to a morphine pump at this point will never be a good idea. It was a way to say tag your it to people, and then, you know, people would do it for a while and then they found out it didn't work. But what Janet suggested is exactly what I did. I held my nose. I told the patient that I wanted to go in a different direction and I wanted them to bring their spouse in. We're going to talk about it. It wasn't what they thought they were looking for, but we were going to get them ready to go in a different way. And we had a couple stops and starts. This occurred around the holidays, and the patient was just scared to death. Family was coming in. We really had to kind of go over the conversation several times, but we finally did switch them over, and we did the microdose induction, and it went quite well. Yeah.
There was a question too, how about the patient with chronic pain and you switch them to buprenorphine, but you know they smoke marijuana? Do you have any issues with that?
excellent question. So I would have issues if I was prescribing C2s, right? I would be very anxious about that. And you don't want to be treating an individual with a potential use disorder or recreational use of medications with medications that are primarily about potential for abuse. But if I had an individual who came into my clinic with opioid dependence or opioid use disorder, and I was switching them to buprenorphine without the use for chronic pain, and they continued to use alcohol or cannabis or what have you, I would wish they weren't. I would try to counsel them away, but harm reduction principles say continue to prescribe, right? So I would counsel that the best way to treat that patient is harm reduction, is to reduce their chronic pain and then figure out why it is that they're continuing to use cannabis. Work with them in that regard. And I do think you can justify co-prescribing of buprenorphine for chronic pain and the use of cannabis.
Yeah. The Jordan asked the person that you were talking about with the duloxetine and all that. So what is his drug regimen now? What all were you able to drop by adding buprenorphine?
So this last case, so the strategy we used, we got rid of the long-acting morphine and we went up on Dilaudid, believe it or not. That's always a scary way to go. At first, we really kind of, we went to daily on the morphine extended release and then replaced some of the Dilaudid, got an idea of how much we were replacing. Then we went up on the hydromorphone, and then we did a very, very slow induction of buprenorphine to the point that I had more than one prescription where there was Dilaudid along with buprenorphine initially. First they had a week, and then we did another 10 days, I believe. And we just said, let's get away from that medication. And at that same time, I guess I should say prior to that, I also, before we switched out of the morphine and hydromorphone, I translated alprazolam into Klonopin or clonazepam. I wanted a longer acting, a milder benzodiazepine, and I wanted to kind of mitigate some of that particular Xanax risk while he would accept that before we switched out of that. So now this individual then ended up on buprenorphine. We ended up with a final dose. This individual is actually taking 16 milligrams a day of buprenorphine, suggestive of a little bit more dependence, right? That's what the MME number would tell us. But they're now on, I think they're entirely off of their clonazepam. That's something that happened later. They're still on duloxetine and pregabalin, and their pain score, I just checked in anticipation of this because I was going to bring this up. When they came to me, they were the patient describing 12 out of 10 pain, right? Everyone has that patient, but really it was about 8 or 9 most days, and now they're talking about 3 and 4. And I can't do better than that with an expensive morphine pump, which I put into, but yeah. Excellent. Does that make sense? I'm really curious. I'm really curious if folks feel like this is something doable, and because I know a lot of people have to make a decision to treat substance use disorders, but I think so many of us treat chronic pain patients, and we're kind of ambivalent about how we're prescribing it. So if you develop this toolkit, I think people will really find avenues to a whole new group of patients they'll be comfortable with, and we'll move things forward. So if you guys have questions about it, this is an area where this team really wants to be answering your questions, not just on Friday mornings every other week. So reach out. We are very happy to work through this, because once you learn this, it's really a rewarding part of your practice.
Yeah, absolutely. The best way to connect with one of our echo experts is just to contact me. You've got my email, and my cell phone number is in the email line, so you can call me, text me, email me, however we can get you connected. Looks like we're at the end of our hour here. I dropped a link to the evaluation survey to get your CME. I'll also be emailing that out here in an hour or two. We hope to see you all in 2 weeks. John and Todd are up next. doing a talk on addressing patients with complex pharmacology and multiple medical diagnoses. So, looking forward to that one, and thanks for joining us this morning, everybody.
Thank you, John. It was very good.
Thanks, you guys. Thank you.